class in such a way that the slides are quite explanatory. Okay, so we are going to go through it very fast. So blood group, as we know, refers to an individual's combination of red blood cell surface antigens. Those are the things that are referred to as the blood group of that individuals. And these antigens, as we said when we are discussing the ABO blood group, there are specific sites on different proteins or glycoproteins or glycolipids that form the parts of the red blood cell membrane. These antigens are specific sites on the membranes of the red blood cells, which the immune system interacts with. So the antigens are specific sites on the on different proteins and glycoproteins that form the red blood cell membrane, and the immune system can interact with them. That is why they can elicit immune reactions. So this is what we call the antigens. They are specific sites. Okay. And these proteins, they have numerous functions. They can function as membrane transporters, like we have Diego and Kid. These are other blood groups. They are from the other blood group. We have those that are receptor and adhesion molecules, like the Duffy and Lutheran. We have complement regulatory glycoproteins. We have enzymes, those that function as enzymes, and we have structural, those that function as structural components or components of glycolysis. Okay, the MNS, glycolysis. So we say that antigens are defined by antibodies that occur either naturally due to encountering antigens that are numerous in the environment, or they are formed as a result of active immunization to non-self red blood cells. Okay, so you can also define the antigens by identifying their antibodies. Okay, that the body, by identifying the antibodies. So in the presence or absence, in the presence and absence, in its presence, that is in the presence or absence of this antigen due to inherited variation of red cell surface antigen that defines the blood group of an individual. It is the presence or absence, okay, due to inherited, that is the antibodies, due to inherited variation in red cell surface antigens that define the blood group of an individual. So the blood group are officially defined as systems of one or more antigens governed by a single gene or complex of two or more closely linked homologous genes, and that each system is genetically discrete from every other blood group system. Each of the blood group system are genetically different from the other one. In order for a blood group system and its antigen to be recognized, the underlying genetic variation must be identified, sequenced, and confirmed to affect phenotype. So during the discovery of the blood group antigen or system, for them to confirm that this is really a blood group system, they must identify the genetic variation that is responsible for expression of that antigen, and they will also be able to sequence, do the DNA sequence of that gene, and also confirm that by manipulating that gene, that the characteristics or the function of the red blood cell also differ. That is, it affects the function of the red blood cell when the gene that is responsible for the expression of that blood group is manipulated. So they want to associate the identified gene sequenced with the characteristics it's manifesting on the red cell, on the red cell property. So this is the process of confirming that this antigen that they identified on the red blood cell membrane is an antigen, because they've been able to link it to a gene, and they've been able to sequence the DNA, have a DNA sequence of that gene, and in experimental manipulation of that DNA, studying the effect of silencing that gene, that the function of the red blood cell associated with it are also affected. So when there is this link from phenotype to genotype and then function, they'll be able to establish that this must be an antigen that is on the surface of the red blood cell, which also interacts with the immune system. So in order for a blood group system and its antigen to be recognized, okay, I've said that, because blood group that are being recognized have been constantly increasing with more advancement in the process of studying the red cell membrane. They've been able to be identifying more blood group system, and this is the process they are used to establish that the antigen they are seeing on the surface of the red blood cell is actually a blood group. Okay, so the International Society of Blood Transfusion, the ISBT, its working party for red cell immunogenetics and blood group terminology, maintains an official record of all currently recognized blood group systems. So research is still going on if they will still discover more blood group system on the red blood cell. Okay, so it has not stopped, it has not ended. I think up for now, currently as at October 2024, they have up to 47 blood group system. Okay, there are currently 47 recognized blood group system containing 366 red cell antigens as at 2024. So, and more may be discovered. Okay, so the 47 system are genetically determined by 72 genes. So this is the record from the ISBT. Okay, so classification of the, is there anybody waiting here? Excuse me. Okay, so classification of the blood group system based on reactions with proteolytic enzymes. So we somehow blood group are being classified based on various terminology, based on various characteristics, but using how they react with enzymes, we can say that there are some blood group system that enzyme enhance their activity, or that enzymes decrease their activity, or they are unaffected by enzymatic activity. So such blood group system that are being enhanced with enzymes include ABO related blood group systems. And under ABO related blood group system, we have the ABO and the H system. We have the Lewis, have the I, have the P. Those, okay, we also, the rhesus blood group system is enhanced. Its activity is enhanced by protein. The KID also, its activity is enhanced by proteolytic enzymes. So this blood group system, MNS, Duffy, Lutheran, their activities are decreased by proteolytic enzymes. Kell system, Diego system, Colton system are unaffected by proteolytic enzyme activity. So that's on based on that's on classification of a red blood cell. So as we said earlier, that currently as at October 2024, that they've identified 47 red blood cell antigens. And when we look at this table, it tries to show us, I don't know if I can zoom it. Okay, sorry. Tries to show us some of these blood groups that have been identified. You can see from number 1, which is the ABO. Okay, you can see some of the things, the system symbol, the gene name, the R range, again, LRG, number of antigens present, chromosomal location, and the CD numbers. Okay, So these are some of the things that they were able to link this antigen on the surface with the gene that is responsible for its expression and the chromosomal locations. Okay, so we have number one, ABO-MNS. You can see it up to 47. Oh, 48. As at here, you can see this one, 47, 48. Is there anyone that they have not confirmed properly? Okay, 47, 48, as defined by the Hugo Gene Nomenclature Committee. Okay. So these are the antigens that have been identified on red blood cell surfaces. All right. So general characteristics of these antibodies, generally clinically significant ones. Okay, are clinically significant. Some of them cause hemolytic transfusion reaction or hemolytic disease of the newborn. Some are warm reactive antibodies, usually IgG. They require exposure. They cause HTR and HDFN. They react best at indirect antiglobulin tests, usually require exposure. So their characteristics is that they can be clinically significant, they can be warm reactive, they can also, some of them are cold reactive, usually IgM, and those ones are naturally occurring. Okay, reacting best below 37 degrees, often naturally occurring. So these are general characteristics of antibodies, trying to point to you when you are considering any antibody. What do you consider? First of all, consider the antigen. By considering the antigen, you should remember the gene location and all that. And then when you consider the antibodies, this antibody, is it IgG or IgM? Does it cause any significant transfusion reaction, or does it cause hemolytic disease of the newborn? What are its characteristics? Does it have a significant effect on transfusion or in pregnant women? Those are the things you will be finding out, because it's necessary, because in blood transfusion, if there's facility or kits to identify these other blood group antigens, you go on to do them, because some of them, if we don't match them with donor and patient, they may cause hemolytic disease of the newborn, or they may cause hemolytic transfusion reactions. So that is why it's good to study it, to know their characteristics, and to be on the watch out, especially when you are in a blood bank. So we're going to look at the resource blood group system. I hope have we done resource blood group? I hope we have not done resource blood group. Okay, the resource blood group system. I think we did only ABO first. Okay, so after the ABO blood group, the resource blood group is the second most antigenic and clinically important of all red blood cell antigens, with the D antigen being the most clinically important within this system. So alloantibodies to resource antigen represent some of the most common alloantibodies identified, and they are generally considered clinically significant. You should also know that. Okay, resource anti-D is very, very common, so I hope you've come across it before. There is up to an 80% risk of alloantibody formation when resource negative patients are exposed to D antigen positive blood, which is responsible for most severe form of hemolytic disease of the newborn. Okay, so when a mother is resource negative and is carrying a resource positive fetus, there is 80% risk of developing antibodies, antibodies that can attack the fetus. Okay, so let's leave it there. As we continue, we see how it's been prevented and all that. So the resource antigens, what are they? The most clinically important are the D, big C, small c, big E, small e, are the most clinically important. These 5 major rhesus antigens were identified in the 1940s. There is no alternative alleles to the big D, okay? It is either expressed or not expressed on the red blood cell surface. Tippett in 1980 discovered that all rhesus antigens are coded for by 2 genes, the rhesus D and rhesus CE, both located on chromosome 1. The rhesus anti-D gene encodes the D antigen, and the rhesus CE gene encodes the rhesus CE proteins to produce the big C and the small c, and also the big E and the small e antigens. So you can see slides is explanatory. The phenotypic frequencies of rhesus antigen expression vary by ethnic background, as we can see in the next slide. A third gene, rhesus AG, located on chromosome 6, encodes for an rhesus-associated glycoprotein, which is needed for expression of rhesus antigen. So this is the genetic description of the rhesus blood group. The genes D, big C, small c, big E, small e. Okay. So distribution of rhesus gene in blood donors of eastern region of Saudi Arabia in other populations. So this is a distribution from this study in Saudi Arabia. I don't think we have such data for our environment. So the antigens, you can see the rhesus antigens, D, C, small c, E, small e. Current study, this is their frequency, Indian population in Caucasian Africa. This is Africa, but okay, Chinese. So it depends on the African countries where they got the data. Okay, a patient genotype can have one express copy of rhesus D, 2 express copies of rhesus D, big D, or no express copy. Phenotypically, patients with either D or big D, small d genotype will express the D antigen and are said to be rhesus positive. So a patient with small d genotype will not express any D antigens on the red blood cell and will be rhesus negative. So the once you inherit the big D, you express as rhesus positive. If you don't inherit express the big D, you are classified as rhesus negative. So in contrast to the D allele, okay, this big C and the big E alleles are inherited like normal allelic variants as CE, CE small c, big C, small e, or small c, small e, with both alleles of the rhesus CE gene being expressed. Okay. Advances in molecular sequencing of rhesus gene have identified at least 58 different rhesus phenotypic variants. Genetic recombination events can create novel hybrid genes between rhesus D and rhesus CE, but the discussion is beyond our scope. So we said earlier that the rhesus antigen, we have the rhesus D, okay, which is being governed by rhesus D, by the gene rhesus D, and then we have the rhesus CE. So in expression, we have that the D alleles can be either big D positive or no expression of the rhesus D gene. But for the C and E, the alleles are inherited like other normal allelic cells, unlike the D allele of the rhesus blood group. Okay. So you'll be able to know the genes that are associated with rhesus blood group system. That's the main thing. The antigenicity of the D antigen depend on its density on the transfused red blood cells. Okay. Proteins patient may express the D antigen at a much lower level. This is termed the weak D gene. So based on the level of expression of the D antigen, it affects the immunogenicity, that is the activity of the D antigen. So that if the expression is low, then the activity or reaction of the resource D will also be mild or low. And we classify that low expression of the resource D as weak D. They are not strongly reactive. Okay. Weak D patients may test as resource D negative by serologic method, although if weak D red blood cells are transfused into a truly D negative patient, the patient may alloimmunize or express a hemolytic transfusion reaction. So it is very, very critical that during the process of blood grouping or cross-matching, if any patient is any resource D negative blood must be confirmed to be truly resource D negative, and not that the patient is resource weak resource D is reacting weakly. If you wrongly classified such patients as resource negative, it may cause some problems. Okay, we'll see the scenarios where this applies as we go on. Excuse me. If weak D red blood cells are transfused into a truly negative patient, the patient may alloimmunize or express a hemolytic transfusion reaction. So in such scenario, probably a patient is completely resource negative. Then a donor who is weak D that is wrongly classified as resource negative, and this donor is being transfused to a patient that is truly resource negative, you find out that there will be an alloimmunization and there will be some lysis of the red cells. So conversely, weak D patients who are pregnant, this is another scenario where it can lead to some complications of transfusion in pregnant women. When a woman is weak D, you say, okay, weak D patients who are pregnant with a negative fetus will not need resource immune globulin prophylaxis despite serologic negative testing, because they are weak. They're almost like, here you can see them as positive and they are carrying a negative fetus, so there won't be any challenge. Okay, other forms of weak D expression exist, such as DEL. However, discussion is also beyond our scope. So blood donors who express small amounts of D antigen, pay attention, small blood donors who express small amounts of D antigen, so whose D antigen reacts weakly, they are weak in reaction, must be labeled D positive to prevent alloimmunization to resource negative patients. I hope that is clear. As such, it requires that D negative blood donors are tested for weak D. So when a donor presents to the clinic and say that is resource D negative, so he should be screened properly to make sure that he is not weak D. Because if he is weak D and a patient is giving that blood that is weak D, it will elicit an immune reaction. Women of childbearing age with resource D, possible weak D, should undergo resource D genotyping, as weak D type 1, 2, or 3 do not need prophylactic immunoglobulin during pregnancy and can receive rhesus D positive transfusion if they are weak D. Okay. In addition to the weak D antigen, there is another variant known as the partial D antigen. So this rhesus blood group has a lot of groups under it. So the partial D antigen is formed by a hybrid gene rearrangement between the rhesus D gene and the rhesus CE gene. As a result, the host is able to form antibodies against these missing residues and can develop an anti-rhesus D alloantibodies if transfused with rhesus D positive cells. Partial D antigens can be identified via extended anti-serologic testing and a panel of anti-D reagents or by molecular sequencing. Clinically, patients with partial D should be considered D negative, and blood donors with partial D should be considered D positive. Clinically, patients who are partial D should be considered D negative. Okay, and blood donors with partial D should be considered D positive. So that while donors with partial D should be considered as D positive, so that there won't be any mistake of giving their blood to a patient who is truly D negative, because if you do that, then that patient will develop alloimmunization and may have some hemolysis. So if it is a donor that it's with partial D, is considered D positive. So those are some of the consideration that is being made. So the anti-C, small c, big C, and anti-big E, small e antibodies are produced in response to different epitopes on the rhesus CE protein. That is the gene. There are two alleles to rhesus CE, both of which are expressed. Both of the alleles are expressed. That is the big C and the small c, and the big E and the small e antigens. Their expression, okay, and it follows Mendelian rules of inheritance, but they are not codominantly expressed. Similar to rhesus D, there are several variants of rhesus CE, with a variant E antigen being the most common. So the variant E is the most common. Okay. The antibodies to the rhesus system can be directed against the D, C, small c, big C, E, big E, small e antigens, or any variant thereof. But we will focus on our anti-D, C, small c, E, small e. The D antigen is the most immunogenic of the rhesus system, the D. About 80%, it gives about 80%, 85% alloimmunization. So any cross match of the rhesus D can result in immune reaction, to the extent that transfusion of a portion of 1 unit, just a portion of 1 unit of rhesus incompatible cell, is can elicit an antibody response. Okay. Interestingly, the remaining 15% of patients that do not form detectable anti-D antibody upon first exposure are termed non-responders. And among these non-responders, half of them will still form an anti-D antibody upon subsequent exposure to rhesus incompatible cells. So 85% of them will respond by alloimmunization, while the remaining 15% will still have about half of them that, although they mounted an immune response, but it was not so potential, it's not so complete, what would I call it, not so strong enough to elicit response at the first exposure, so that at the second subsequent exposure they will be able to develop immune reactions. So this population of patients or persons are termed non-responders because they did not respond at the initial first time of exposure to the antigen. The anti-D antibodies can wane over many years. That is, their potency can decrease and have been detected up to 38 years following exposure. If the antibody is not detected by serological method, the patient will remain immunized to the D antigen through lifetime. So the anti-D, okay, is an IgG class antibody, the anti-D. It can cross the placenta and cause a severe form of hemolytic disease of the newborn. In the situation where a mother is rhesus D negative and she is carrying a rhesus D positive fetus, her system can develop antibodies that can, these anti-D antibodies, and these antibodies can cross. Okay, that will give rise to the hemolytic disease of the newborn. Okay, so the maternal formation of the anti-D antibody, the maternal formation of the anti-D antibody can be seen as early as 2 months and as late as 5 months. Although anti-D, IgG, and Ig3 subclasses have been demonstrated, anti-D generally does not fix complements efficiently. You see some of the lapses they have, although they cross the placenta, but they don't fix complements efficiently and more often result in a serologic transfusion reaction. They result in serologic transfusion reaction. They give rise to extravascular clearance of antigen positive red blood cell. Anti-D is primarily detected via the indirect antiglobulin test. So these are some of the characteristics or properties of the anti-D. It's IgG and all that. Formation of anti-D antibody in patients has been increasingly rare due to introduction of the rhesus immunoglobulin prophylaxis in the late 1960s. So the anti-D antibodies, their formation has been a little bit has been controlled, is under control, okay, combined with the standardized use of rhesus D typing to detect patients with weak D, okay, and partial D variants. So because of the development in experiments and study and research, okay, patients that are weak D or partial D mothers, okay, in the course of their pregnancy with positive fetus, they are given IgG, rhesus immunoglobulins, okay, to prevent the alloimmunization. Rhesus IgG, that is rhesus immunoglobulin, acts by binding the rhesus positive red blood cells, okay, and shields them from immune recognition. So this rhesus immunoglobulin that have been given to a rhesus mother who has a rhesus positive baby, you know, the rhesus IgG will cross the placenta. They will cross the placenta and shield these red blood cells of the fetus so that the body immune system of the mother will not recognize it as foreign and will not develop antibodies against it. So that is how the immunoglobulin that is giving them functions. It acts by binding the rhesus D positive red cells and shields them from immune recognition, thereby preventing the formation of anti-D by the mother who is rhesus negative. There are few scenarios, however, that still pose a risk of alloimmunization. There are some of the scenarios: pregnant women who receive inadequate prenatal care and fail to receive immunoglobulin prophylaxis are at increased risk of forming anti-D antibodies. Release of eminent resource incompatible units to trauma patients presenting with massive bleeding can result in the formation of anti-D. These are patients that are in danger, maybe accident patients, and they are actively bleeding. If unfortunately they are resource negative and they are giving resource blood, so it poses danger of developing IgG antibody, anti-D antibodies. Okay, anti-D negative patient receiving platelet transfusion, which contain a small amount of contaminating red blood cells. In as much as the immunoglobulin has been used to prevent the formation of uh, resource anti-D, okay, there are some situations where the control um, it's not really taken care of. For example, in this emergency scenario where a patient that is resource negative is bleeding profusely and there is no time to actually do thorough cross-matching of the resource system. So in such situations, and the patient is transfused, there's no way you can stop the body from developing the IgG antibodies. And also immunosuppressed patients receiving resource incompatible platelet units. Sometimes they are giving platelets, but these platelets were donated by persons that are resource positive, and they may be contaminated with some red blood cells containing resource positive blood. So these are some of the situations, scenarios where controlling the formation of anti-D may not be possible and will result to immune reactions. The CE antigens, both big and small, are clinically significant also IgG class antibodies directed against the antigens. Okay, the anti-E antibody is the most common. All cases are naturally occurring. All cases are naturally occurring anti-E, making the anti-E antigen a very weak antigen from the perspective of alloimmunization. Anti-C is the next most common antibody. Be watching the characters, whether it's big C or small c, as you're looking at your screen there. The anti-C, small c, while rare, is notable because it is solely formed because of antigenic exposure. No natural form of this antibody exists. Take note of that. The anti-E, small e, has been reported, although studies show the E antigen to be weakly immunogenic. Anti-E, small e antibody, however, is clinically significant once it is formed. Okay. So we have another blood group system. Like I said, we are not going into detailed analysis of the blood group system. We're looking at their genes, the gene associated with them, the antigens, the characteristics of the antibodies, the characteristics of the antibodies. How does it affect pregnancy? How does it affect blood transfusion? Is it clinically significant? Those are some of the characters, properties of the blood group that you have to be looking at. So we've handled the resource, all the antigens associated with the resource blood system. Okay, you have to know it, the chromosomal location and all that. So we have another blood group system called the Kell blood group system. This system have at least 34 antigens. It is the third most immunogenic following ABO and resource. Compared to resource antigen, the K antigen is approximately 8 to 10 times less immunogenic. The Kell antigen are encoded by the Kell gene located on chromosome 7q33 and carried by the Kell glycoprotein, a 93 kd single pass membrane proteins. These are and genetic associates. The most clinically encountered antigen, you can see the antigen associated with the KL blood group, KPA, and all that. Okay. The K antigen within the KL system, the K antigen and its alternate allele, the small k, is the most frequent clinically. Both K antigen are encoded by a single protein that differ only by a single amino acid substitution. These are genetic terminologies, okay? The K antigen, the big K, is expressed in approximately 9% of whites and 1.5% of blacks, either in homozygous or heterozygous forms. In contrast, the small k is present in nearly 100%. Additionally, also on 7q33, code for the closely related antigens, the KPA and KPB antigen differ by a single amino acid substitution, W and R. Okay. Similarly, JSA and JSB antigen differ by a single amino acid substitution. This is just a description of the genes that are associated with the K antigen of the KL system. The anti-K, the antibody. After ABO also and rhesus antibodies, the anti-K of the KL system is the most common alloantibody with incidence between 14 to 28%. The risk of forming an anti-K is 10% if an individual is transfused with at least 1 unit of K and positive blood. You can see it. They fix complements, although they do that incompletely. They do not cause formation of membrane attack complex. In as much as they fix complements, they do not attack the membrane complex. That is good. Predominantly, they are IG1 class antibody, being an IG, therefore capable of causing severe hemolytic transfusion reaction. In addition, severe hemolytic disease of the newborn can occur in K antigen positive fetus due to ability of the antibody to cross the placenta and clear fetal red cells from circulation, as well as bind and destroy fetal erythrocytic precursors, which express the K antigen early in lineage development. As a consequence, severe fetal anemia results due to suppressed fetal hematopoiesis. That is explanatory. Now, the frequency of the antibody in pregnant women is approximately 1 in 1,000, and the incidence of hemolytic disease of the newborn due to K is estimated to be 1 in 20,000. Is different from other cases of maternal fetal alloimmunization, where the antibody titer correlates with the severity of fetal anemia. Anti-K titers do not correlate with the degree of anemia. In the presence of maternal anti-K antibody, the rate of high drop of fetal death ranges from 15% to 38%. Although anti-K is by far the most prevalent and severe cause of fetal hemolytic disease of the newborn fetus, okay, the JSA and JC and CABA antibody have also been associated with hemolytic disease of the newborn. So it's clinically significant. The KL blood group system is clinically significant, especially because of this K antigen that is part of the system. In contrast to the big K, the small K antibodies is rare. It's a rare one, and the incidence is quite low. Okay. The KPA and KP are also rare, as are also the JSA and JSB. Okay, so similar to the K, they too are capable of mediating hemolytic transfusion reaction, but the frequency of the other antibodies associated with the KL blood group system are quite low and also rare. Now we have another blood group system called the KID blood group system. We are not going to take all the blood group systems, okay? We just take few of them, very few of them. Okay, we have the KID blood group system. It consists of the antigens. You can see the antigens associated with the KID, okay, encoded by this gene located on these chromosomes. The KID protein is known to function as a urea transporter in the red blood cell membrane, transporting urea out of red cells as they pass through the regions of high urea concentration, and thereby preventing what? Dehydration. These antigens are predominantly expressed and differ by the mutation polymorphism. The JK3 phenotype is present as an incidence of 1.4 in some Pacific Islander population where the study was carried out. So the study of the frequency of the phenotype is based on population. Okay, so that when you give the incidence of any of the red blood cell antigen, it's a population-based stuff. You can't generalize it except if you've done study in that population to be able to know the frequency of that blood group. So what about the antibodies associated with the KID blood group system? The most common is the anti-JKA and anti-JKB antibodies, and there are IgG1 and IgG2, but 3. They also have IgG24 and IgM components also exist. The frequency is 21% for anti-JKA antibody and approximately 1% for anti-JKB in the US population. Two important features of anti-JK and JKB antibodies are their ability. Who is Imoni Juliet? Always off and on, always off and on. Two important features of the anti-JKA and JKB antibodies are they have the ability to fully activate the complement cascade. So you mark this property, these characteristics for this KID blood system. Okay, their ability to fully activate the complement cascade, resulting in delayed acute and serologic hemolytic transfusion reaction, which is due to their ability to fall to undetectable level by conventional serologic methods, but just several months following alloimmunization, a phenomenon known as antibody effervescence. So they have this ability, okay, to be undetected but on the background and can cause some immune reactions. The JKA and JKB antigens have a role as minor histocompatibility antigens in renal allografts due to the high concentration of the JK antigens on the renal medullary tissue. You see this blood group system playing a very significant role in kidney transplants because of the concentration of these JK antigens on the renal medullary tissue. So they have an important role to play in kidney transplant, so that in the process of kidney transplantation, this antibody must be fully cross-matched in the donor and the recipients. Okay, because any mismatch in this blood group system can result in rejection of a kidney transplant. So when you are reading about any blood group system, you go in details to know how it contributes to the immune system of the body. Likewise, any immune reaction, you can see here, we are witnessing an antibody that interferes with, that is interferes with the histocompatibility of the system. Okay, so it's very important to note that. So we also have the Duffy blood group system. What is significant about this system? You ask yourself. So don't just read for reading's sake. When you read and ask yourself questions, what is the significance of this blood group system? How does it contribute to blood transfusion? Does it contribute? Does it complicate blood transfusion? Is it significant if it's not cross-matched during the process of blood transfusion? Can it elicit any immune reaction? How will it affect transfusion or pregnant women? So these are the questions you have at the background of your mind as you read any blood group system, even the ones that are not contained on the slide. You go ahead to find out if there are other ways they play clinical role in transfusion. There are 5, the Duffy blood group system, another blood group system. There are 5 antigens, see, in the Duffy system, including all this up to 6 or 5, okay. Antigens within the Duffy blood group system are coded by the DARC gene, which codes for CD234, which codes for the receptor protein that binds inflammatory cytokines, the interleukin C8, monocyte chemotactic peptide, and the melanoma growth stimulative activity. So this is about the gene. The most commonly encountered antigen within the Duffy system are FYA and FYB, which are expressed codominantly and differ by the G42D polymorphism. This is a genetic mutation. Approximately 2/3 of Blacks in the US express neither antigen, neither this or that, and some population worldwide show 100% of the population with this phenotype, negative phenotype. Okay, this is also as a result of some genetic mutations. The FY antigen is expressed on either tissue, on other tissues, sorry, preventing alloantibody formation in these patients. Cases also exist where FY and FYB antigens are missing due to deletion or other inactivating mutations. The explanation is given in red. Okay. What about the antibodies to this blood group system, the Duffy blood group system? The antibodies FYA are present in about 30% of patients, with anti-FYB being much less common. There appears to be a strong association between the FYA formation and the human leukocyte antigens. Okay, so this is playing a role in also organ transplants, okay, indicating that presentation of the FYA antigen may be dependent on a very specific antigen presentation configuration. The anti-FYA and anti-FYB are predominantly IgG1 class antibodies and are known to cause both acute and delayed hemolytic transfusion reaction, as well as hemolytic disease of the newborn. I hope so. Okay. An association, there is also an association between this blood group system, okay, and Plasmodium vivax and Plasmodium novellesi, and patients with FYA or B null phenotype is well known. So there is an association between this Duffy system and malaria parasite. Maybe this blood group system will be very, very frequent in our population. The Duffy glycoprotein is the receptor for the malaria parasite. Is there any other blood group system we have mentioned that is associated with malaria parasite? For now, none. So it was discovered that the Duffy antigens serve as a binding site and point of entry for these parasites into red blood cells, and patients with Duffy FYA and B null phenotype are resistant to red blood cell infection by malaria. So because they lack the antigens where this parasite attach, so this parasite cannot affect their red cell. You can see it. This may explain selective evolutionary pressure towards FYA and B null phenotype, you see, in malaria endemic regions. Duffy antigens are destroyed by proteolytic enzyme. Okay, that's a good one. The MNS blood group system. They are notable for marked antigenetic diversity. Okay, there are over 46 different alleles currently identified within the blood group system of this MNS blood group. Okay, the antigens are encoded by these genes, homologous genes located on chromosome 4. The red one tried to describe the gene, so I wouldn't go into that. Glycoprotein B also serve as a binding site for the C3b complement component of the complement cascade. The MNS system is divided into MN and S, big S, small s loci. Both of these alleles follow Mendelian inheritance and can be expressed codominantly, making all possible permutations. As you can see, big M, big N, big S, small s expressions are possible from this antigen. The big M, big N antigen are expressed on glycoprotein, on GPA, while the big S and small s and U antigen are expressed on GPB. Explanation given in red. The S phenotype is rare and found in approximately 1.5%. Okay. What about the antibodies that are associated with this blood group system? We have the anti-M and anti-N alloantibodies that are common. They are naturally occurring. So if they are naturally occurring, what can they do? They are co-reactive antibodies, all of which are at least partially IgM class. Auto anti-M may be IgG alone. Up to 4% of infants and adults are found to have anti-M that is reactive at 37. Therefore, anti-M is a clinically significant antibody because they've identified some persons that have IgM that are reacting at 37. IgM alloantibodies have been demonstrated to form up to 12% of time in the context of alloimmunization. Although anti-M and anti-N do not bind complement, they do not bind complement or mediate intravascular hemolysis. Are you seeing that? There are case reports of delayed hemolytic reaction due to anti-M and anti-N. In addition, they are not implicated in hemolytic disease as they are IgM class antibodies. That is well anticipated. The anti-S, big and small s in this MNS system are typically IgG, unlike the IgM. Antibodies are reactive as 37, therefore they can mediate hemolytic transfusion reactions. They have high incidence of U antigen, is a shared epitope of the S and the S antigen, both big and small. Patients that are SS are capable of alloimmunizing to you, as well as forming a clinically significant anti-U, which can cause hemolytic reactions. Okay, so I think this will stop at this MNS blood group system for now. Okay, so thank you for attending the class. This is the other blood group system we are going to take for now. Okay, so if you have any questions, you can